Welcome to Ezisurg. We are committed to providing complete minimally invasive surgery solutions worldwide through the industrialization and R&D of high-end tumor minimally invasive surgery medical devices. In more than 10 years, we have tripled our functional floor space and developed technological and managerial know-how that allows us to compete on a global level successfully.
Our headquarters in Shanghai, our production facility does more than just produce minimally invasive surgical products. It's also an advanced competency facility, which allows our engineering and development team to work closely together to better test, optimize, and develop new cutting-edge technology.
We are committed to improving surgical outcomes in bariatric, thoracic, and colorectal procedures. Ezisurg has a comprehensive MIS portfolio focused on addressing surgical challenges. We create value all over the world. We're supplying medical professionals and treating patients in every continent. We fully support the development of academic interchange between surgeons, promoting the progress of new techniques, serving top medical institutions worldwide. We are certified by international standards such as FDA, CE marking, and MD SAP. At Ezisurg, we are committed to making people's life better.
喂，可以开始了吗？可以开始了是吧？Okay, ladies and gentlemen, I'm pleased to be here with you this evening. My name is Zheng Jie, and I am a thoracic surgeon at the Zhejiang Cancer Hospital, China. I will be your host, and the duration of this conference is called East Asia Surgical Webinar Series. The first episode, the most technical challenging segmentectomy during thoracic surgery solutions. As we all know, the thoracic scope is developing rapidly, and more surgeries can be performed during thoracoscopic surgery. Not only lobectomy, but also segmentectomy, subsegmentectomy, and also sleeve resection. But at the same time, some problems remain solved, such as in identification of intersegmented plane, and the localization of the GGO. Tonight, we have invited 4 famous professors to give us presentations. We are going to talk about the topic about segmentectomy in use our thoracoscopy, and hopefully you will find that interesting. We have 4 presentations for you this evening. Tonight we have invited 4 famous professors to give us presentations. We're going to talk about the topic. Each presentation will last around about 20 minutes and will divided by one of our guest professors. The first, I would like to welcome Professor Fan Junqiang. Mr. Fan comes from the second affiliated hospital, Zhejiang University School of Medicine. He is a chief vice direct department of direct surgery, member of the lung cancer group of the thoracic and cardiovascular surgery branch of the Chinese Medicine Association, and has many other academic positions. And now, welcome Professor Fan. Welcome.
Yeah, thank you, Professor Chen. Good evening, everyone. Thank everyone. It's my honor to speak here. My topic is application of fluorescence endoscopy in pulmonary segmentectomy with uniportal VATS. I'm from the second affiliated hospital of Zhejiang University. Segmentectomy, we know with the high level resolution spiral CT and increased in case of ISPN and particularly stage 1.
Mr. Fan, we cannot see the PPT.
Oh, sorry. Yes. Okay. You can see the presentation.
Yes. Okay. Yeah.
Okay. My topic is application of fluorescence endoscopy in pulmonary segmentectomy with uniportal VATS. I'm from the second affiliated hospital of Zhejiang University. The background with the high resolution spiral CT and increase in cases of ISPN and particular stage 1A lung cancer and GGO, hyperlateral, bilateral, and multiple agents, elderly population and patients with multiple complications. Jacob 0802 publication of non-inflated RCT study results. Segmentectomy is now worse than lobectomy for early lung cancer, less than 2 cm in diameter, and the CTR more than 0.5. In our surgical group, the population of sublobar dissection was about 50%. For segmentectomy, about 30%. Surgical indication for segmentectomy, we refer to the NCCN guidelines, just like ages than 70 years, patients with poor cardiopulmonary function or other combination who cannot tolerate lobectomy, and GGO lesions and benign pulmonary nodules that not require lobectomy, and the metastasis lung cancer not suitable for visualization, or multiple pulmonary lung cancer. Extension of surgical indication, Jacob 0802 study. Pulmonary nodules more than 2 cm, GGO with 50% gland. Now we can extend to peripheral nodules more than 2 cm and the CTR with 0 to 1. This is the anatomy of lung cancers, lung segment, and this is a subsegment. We should, with familiar this anatomy. Character of soloscopic segmentectomy, from pneumectomy, lobectomy, segmentectomy, and subsegmentectomy, combined subsegmentectomy. It's extensive to fine, extended surgery time, extended learning curve. Some complex of segmentectomy anatomy and variation in anatomy between individuals make a segmentectomy more difficult than lobectomy. 19 segments have different modules of evolution. combined with the subsegmentomy dissection, it is ever-changing. Key point of segmentomy: preoperative planning, target the segmental plane, clopping the intersegmental plane, cheat iliac of intersegmental plane, anterior planning, centered on pulmonary nodules on target region, centered of segmentomy to centered on regions 2 centimeter margin, ensure adequate liquefaction margin, combined subsegmentomy, combined segmentomy or segmentomy and visual dissection. We just like use 3D reconstruction, just like this. This patient with S1B, S3A, and S2B subsegmentomy dissection. Preoperative 3D reconstruction. This is just like RS2 dissection. We make 2 centimeters around the nodules as the edge. The edge simulate the lung segmental plane, just like this. This patient with a combined LS1 and 2 subsegment and S4AI and subsegment and S7AI segment combined dissection. The lesion is there, focusing on the nodule with a radius of 2 centimeters long. Targeting the segmental plane, there is modes of methods: lung inflation, corpus lung, inflation deflation method, inflation part of the lung, high frequency ventilation, positive in the bronchoscope, bronchial injection method, careful of air embolism, staining method, below method, endocassial green flow method, fluorescent sonography is required. We use this usually. Determinations of plane on segment by pulmonary artery, determinations of plane of the segment by bronchus, normal staining method. This is a result staining method. Application of intraoperator fluorescence improves the marketing speed of segmentomy. The advantage is fast institute, minimize the potential lung injury from inflation repeatable procedures. Disadvantages: too fast, unclear demarcation in the segment, unclear demarcation in patients with emphysema or pulmonary surface vascular proliferation. We use injection volumes 3 to 5 millimeters. Classic pulmonary segmental intersegmental vein add function. This is important to be to use as intersegmentomy plane, just like B1B, B6, B3C, or B6B, or B6C. This is an inflation deflation method, just like this. This is a B1B. This is an anterior segment apical segment. This is a use in fluorescence staining to identify the intersegmental plane. This is a S9 to S10 segmentomy. Advantage is just like quicker, less waiting time. Disadvantage is too fast. Multiple injections are required, and arterial need to be identified clearly. The intersegmental plane in the brain is not easy to judge. Yes, this video shows the Florence staining ICG to identify the intersegmental plane. The speed is very fast. The staining speed is very fast. We use Hawk to mark the margin. This is another method to use Florence staining to identify intersegmental plane. Use a needle to injection into the bronchial stump. Managing the intersegmental plane, we can use mechanical, just like tearing, scissors, energy, coagulation, ligation, ultrasonic scalpel, or both energy and stapler. We use both energy and stapler. This is a CT shows the chest CT after basal segmentectomy, just like this, just like a run. Severe emphysema of interstitial change. Patient was unable to identify the boundary between segmenta and not suitable for sharper separation, suitable for linear cut. A linear staple, sorry. This shows the electric coagulation Hawk separation. This is a harmonic separation we use to in the intersegmental plane, just like this. We use both and with the staple to deal with the intersegmental plane. Yeah, this is use harmonic to deal with the plane. Yeah, just like this. This is a S3 segmentum. Early prevention at the intersegmental plane. We can use polyloclosure method. Polyglycolic acid with fibroid glue. Yeah, this is a fibroid glue. We should carefully observe the bronchial airicus. We can use a suture. This method is to stitcher, use a stitcher, suture the intersegmental planes. This is a video shows S6A and B and S6A resection. This is a combination of subsegmenectomy. This is a 44-year-old female patient was admitted due to light low lung nodules for more than 1 year. Pulmonary function test showed normal. CT showed multiple GGO in the lung, and the main lesion was located in the lateral lobe. This is the lesion, and here, and this is S7 and S8A. This is a lesion. Yeah, this lesion. Yes, this is a 3D construction. Yeah, this is a lesion margin. It shows a video. we use harmonic to dissect the here is a small artery. Yeah, this is A2A. It's a very small artery. Yeah, A2A II. It's injury. This is a A6A. This is a small artery. This is a bronchus, very small. It's a B6A. You can use ligation because it is very small. Now we dissect the S6B. This is another artery, A6B. It's also a small artery, so we use ligation. It's a bronchus, so it's also a very small bronchus. E6B. We use a staple. It's a white staple. A8A. DAA. Because the bronchus is very small, we use a white staple. It's a vein V6B. Yeah, we use ICG to show the intersegmenectomy plane. The staining speed is very fast. Now we use operation to dissect the plane and use a staple to deliver the intersegmenectomy plane. This is regions. Yeah, this is the brain. No air leaking. It's another patient, and this is a patient, 43-year-old woman, is found to have a lateral lung nodule for 3 months. It's an invasive adenocarcinoma of the upper segment. Yeah, it's a lesion in clear. visually section is not enough to the model. So we use S6 section. We usually do 3D reconstruction to show the artery and the bronchus. Now we show the tubulus S6 segmentectomy. This is a tumor. Here is the incision, about 3 centimeters. Intercostal nerve blockage. Vagus nerve blockage. This is the artery. Here is S6 artery. S6 artery. There's a B6. Now we discuss the vein. Here's V6A. Oh no, here's the V6 because the margin. You should preserve the margin. Ensure the enough margin. So yeah, the second is it's not a V6A. There's a small baby. ICT injection. ICT is very beautiful. Second is brain operation. Yeah, now we use a staple. This is a tumor. similar. There are many methods to deal with intersegmentomy plane. The most commonly used is the inflation-deflation method. We usually use the inflation-deflation method because it is convenience. The anatomy of the lens segment is fundamental. Collected transections, targeted artery, and bronchus is critical. Intersegmentomy veins need to be carefully identified and when cutting the intersegmental vein. The ICG method is gradually popularized. Combined with inflation-deflation method, it will be more accurate. Shorten the operating time is a significant advantage of in ICG. Thank you, everyone. Thank you. Thank you for your.
Okay. Thank you, Professor Fan.
Yeah.
Professor Fan is a very famous thoracic surgeon with a very high surgical skills, as we all know, and he gave us a very good presentation about the ICG in the segmentectomy. As we all know, that the intersegment plane is very difficult to identify. There are many ways, but none of which is perfect. The ICG now is very popular. Can solve a segment, can use for the precise segmental resection. Professor Fan is good at a very precise segmentectomy, such as sub-segmentectomy. Thank you for Professor Fan. And now I invite some questions from the other professors. Any question to Mr. Fan? Other professors, any questions?
Hi, Dr. Fang. Very nice presentation.
Yeah.
And my question is, in your air leak, how do you manage if the patient have got prolonged air leak, more than 5 days or so? Have you had any problems in this kind of patients?
他就漏气嘛，漏气，他就说你这个漏气你怎么弄啊？
Okay, I think air leak has a problem in the deal with intersegmental plane, but I think the prevention is very important. So we use staple, not to dissect the plane with coagulation. So we just dissect the plane with coagulation with just a very small area, not complete. This is important, and not to injure the bronchus. If we injure the bronchus, the air leak is very hard. Prevent this situation. This is very dangerous. We maybe the fistula of bronchus. Yeah, thank you.
他还有一个问题就是范主任，他就问你，时间如果很久，他还没有愈合，你怎么办？就是一直在漏气。
This is a very good question. I think the prevention is very important. If we 这个怎么回答呢？这个我们碰到很少。The time is very important. The waiting time is very important. Now we should to identify the bronchus air leak or just pulmonary bulbar air leak，叫肺泡怎么说？就是说要区别这个增加肺泡怎么说？肺泡漏气跟这个支气管漏气。
The pleural leakage, just pleural leakage and the bronchial leakage that is important. Yeah.
This is very important.
In your drainage method, do you use digital drainage or just an underwater seal, like topaz, or do you have?
Yes. 他就问你是不是用水风瓶啊，还是用这种电子的这种引流器？
我们用水风瓶 ，just use water seal bubble.
Okay.
电子的我们没有很多没有用，你们有用吗？郑健？
没有。In China, many hospitals have digital units. Yeah.
Yeah, Dr. Fan, could you hear me?
Yeah, thank you.
Hello.
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 Hello, Dr. Fan, could you hear me?
Yeah, good evening.
Yeah, I'm Dr. Suksan.
Yeah. Hi.
Hi, I'm Dr. Suksan. May I ask you some question?
Yeah.
I want to ask you about lymph node dissection. In your practice, do usually do a lymph node dissection in subsegmentectomy? Always do the dissection or just do the sampling lymph node dissection? I mean that you do a radical dissection or do a sampling lymph node dissection. Do you have any idea about this?
有啊，郑健听明白吗？
对，他是问你就是在做这种亚肺段切除的时候，你做采样呢，还是做清扫？就是对淋巴结。
我们主要是根据这个 GGO 啊。We just determined by the lesion. If the lesion is solid, we use lymph node dissection, or if the lesion is just GGO and the GGO percentage is about more than 50%, we just use lymph node sample. Yeah.
Thank you. And another question is, in your experience, do you notice that any difference between wet resection and subsegmentectomy in terms of disease-free survival or recurrent rate?
Sorry, can you repeat your question? We cannot understand.
Yes. Okay. I want to ask you about your experience in case that you did the wet resection compared to do the subsegmentectomy in lung cancer, and do you ever have some recurrent? Is it have different between two kind of the technique? I mean that if we do the only wet resection, a small resection of the tumor compared to the subsegmentectomy, do you think that this is have any different of recurrence between two groups?
You mean wedge resection and the subnectomy?
Yes. In your experience.
By the location and by the percentage of solid portion. If 外周1/7啊，外周1/7讲不出来。We did just determined by the lesion location and the solid portion of the lesion， 主要是根据这个位置跟这个肿瘤的这个叫什么成分，这个很关键。
As Professor Pham means that it's just decided by the location of the location of the tumor. If the tumor is deep inside, and we prefer segmentectomy. If not, as near the pleural, we can adjust a wedge resection.
Yeah.
Okay. Thank you.
Thank you. Okay, thank you for Professor Pham. Professor Pham, yes.
Yeah.
Now the next professor is Cao Yingkai. Cao Yingkai is our old friend. In many meetings we can meet. Professor Cao Yingkai is from Chang'an Memorial Hospital, Linkou, Taiwan. He is a chief at Department of Thoracic and Cardiovascular Surgery, Chef at Department of Thoracic Surgery, and many other titles. And now we welcome Professor Cao.
Hello, everyone. I'm Dr. Yingkai Zhao from Chang'an Memorial Hospital, Taiwan. And it is my great honor to be invited to this wonderful meeting. And the topic I was assigned today is fluorescence-guided precision lung surgery. And so in the following talk, I will briefly discuss how we use the fluorescence during our daily practice. So I come from Chang'an Memorial Hospital, and Chang'an is the biggest private hospital in Taiwan, and we have totally 10,000 beds all around Taiwan. And I came from the Linkou main branch. It is the biggest branch around the Chang'an Hospital. And this is the lung cancer incidence in Taiwan, and you can see a striking figure that the lung cancer increased a lot in recent years, both in male and female patients. And because of this, our government started the lung cancer screening program very early, and in order to identify more and more early lung cancers. And according to our trial result, that in Asian non-smoking lung cancer population, and the incidence of lung cancer screening, the incidence of lung cancer detected by local city is 2.6%, which was much higher than the Europe and American population. And so for thoracic surgeons, this kind of clinical T1, N0, M0 early stage lung cancer become very popular in recent years. So in the past, we do lobectomy for almost all lung cancer surgeries patients. Now, because of the earlier detection of small lung nodules, there are a lot of issues raised that should we do lobectomy for this kind of small GGO lesions? And this result has proved that by the use of sublobar resection, mainly by wedge resection, we can have a quite good overall survival for this kind of early lung cancer. And for how about this? A small lung cancer, but with more solid component. And this trial, which was published this year, also shows that by the use of sublobar resection and many by segmentectomy could achieve even better survival when compared with the lobectomy patients. So nowadays, in the past, lobectomy for all small lung cancers, and nowadays we can do personalized surgery. We can do wedge resection alone for this kind of GGO predominant lesion if we have good margin. And we can do segmentectomy for this kind of smaller lesions, but with more solid component. So for this kind of cancers, now the current standard of care is precision sublobar surgery. So when talking about sublobar resections, there are three types. The first one is the anatomical, we call the segmentectomy. And the other one is non-anatomical, which was called wedge resection. And I will introduce a new concept that was called semi-anatomical. And I call this kind of surgery as the hybrid segmentectomy. And first, I will talk about the wedge resection. So wedge resection is a very easy operation for thoracic surgeons. However, when we try to do wedge resection for the small or deep or ground glass lesions, it might sometimes be very difficult. And the reason is that because of a small incision of the skin, and we can put our finger into the chest, so we can feel the tumor just by the finger instrument palpation. So we are feeling like this. We are doing a blind wedge resection. It is not safe. So now the standard of care, we better do the preoperative tumor localization for these small lung lesions. So this is the old pathway. So the patient will receive the localization by radiologist. And we call the time from the needle insertion to surgery as the time at risk. And this kind of traditional pathway, the time at risk could be quite long. And because we need to transfer the patient in different places and also waiting for the surgery. And the patient anxiety increase and the risk of pneumothorax, hemothorax, and also the wire dislodge become very common. So my team, we established the Chang'an thoracic surgery, and we established our IVAS protocol since 2016. And we aim to provide a good solution for this kind of small tumors in need of preoperative localization. And the I means image guided. And we do everything by surgeons and using the hybrid operation room. And this is the video of our procedure. So for example, this is the first case in the day, and we start operation in 8:48 in the morning. And we prepare the patients in a lateral position, and from the start of scanning to needle puncture, it takes 6 minutes. And then we start to count the time at risk. After the needle insertion, we repeat the CAT scan, and it takes another 2 minutes. And once we confirm the needle was in the right place, then we inject the marker, and then we will start the surgery as soon as possible. So the total procedure time for localization in this case is 10 minutes. And then we start our procedure, surgery procedure, in 9:02 So the total time at risk is 8 minutes in these patients. And now in my daily practice, the average time at risk is always less than 15 minutes. And because of this, so the risk of pneumothorax, hemothorax, and anxiety will be reduced a lot. So, and this is our main idea of our team. We aim to longing for less. And what does this mean? We try to longing for lesser complications, lesser time at risk, and also lesser extent of resection in lung surgery. So this is our original protocol that we use the hook wire and the methylene blue for the localization of the deep or superficial tumors. And however, for the blue dye, there are a lot of limitations. This is one that the dye will split after the localization, and it will result in disaster because you cannot know where the tumor is. So, and this is another limitation of this the blue dye. For example, this is a good localization. We will see the blue dye on the surface of the lung, and we can make a good resection by identifying the blue tattoo on the lung surface. However, I will show you another cases. This is a patient with severe anthracosis. There are a lot of black spot on the patient lung surface. So in this case, in this case, it is very difficult to identify where the tumor is, and that is the problem. Like this. Okay, and because of this, we started our modification of our dye, and we introduced the concept of fluorescence, the ICG. So we published our first report in 2018, and so far we've performed more than several hundred of ICG localizations. And this is the short video of the ICG. And I'll skip the first part because you see the procedure already. And in the past, we used the blue dye, and now we inject the ICG. Okay. And I will show you different ICG systems. This is the old one, and it mainly by blue light. And before 2016, this was the only available machine on the market. And the main short disadvantage of this was the insufficient light. And this is another one, the so-called Firefly, that was made by the Intuitive. It became better because even with the dark background, you can still see the fluorescence very clearly. And nowadays, our favorite machines like this is another machine that has the we can see the fluorescence in normal white light, and we can see not only the fluorescence but also the normal lung as well, and that makes the surgery much easier. And these three types of machine are all already on the market, and we also use another new machine, and this one has the 4K resolution. You can see the image quality is much better. And now we do a localization, and also we use the this is the easy endo stapler, and we try to do the wedge resection. And you can see there are some small markings on the lung surface. And I have to remind you that this is not really the dye problem. This is a real, you can see the real lymphatic tract on the lung surface. And I think this provides a very important clue for our surgeons to guide us how to do a good wedge resection, because we can see if the tumor has pleural metastasis, which direction will it go? And by a good localization, we can do a very easy wedge resection using the easy endo system. So we published our ICG report this year, and we summarized this several good things and bad things about the ICG localization. So what about the good things about ICG localization is this. So this is a terrible video that you will see. Oh, this is a terrible dye split. And when we use the Messiaen blue, it is impossible to save this to solve this problem. But when you use the ICG, because of the water soluble condition, you can just use a lot of water to wash the lung, and then you can see the real ICG place, even in the case of dye split. And what's the bad things about ICG? First, we think the limitation, the penetration depth of the ICG is a major problem. So for the superficial ones, it can be quite easily to see the tattoo if you put it on the superficial part. However, for the deeper part, if you inject the ICG in the deep lung surface, deep means more than 2 centimeters. And this is an example of the deep injection of the ICG. So when you try to, when you enter the chest, you can't see anything. And that's a very important limitation of the ICG. You see, when you open the ICG line, there's almost nothing over there. So, but when we do the blind wedge resection, segmentectomy, you will identify that, oh, actually we really inject the ICG in the right place. However, because of the limitation of depth, you can't really see the tumor. And that's one of the limitations of ICG. And to solve this, we try several ways. And I'll show you the first way that is not very successful. We try to inject the ICG all the way from the deeper lung surface to the surface of the lung. And this is the terrible video because this is a very technical, demanding injection. And if you can't injection very precise, it will result in the whole lung diffusion on the lung surface. The ICG diffusion in the lung surface, and that will result in a disaster. And you will not allow to identify the tumor in a good way. So what do we do nowadays when we try to localize the deeper tumors? You can still use hook wire, but if you want to avoid the use of hook wire, we propose this kind of dual localization. We use the ICG based and plus the microcoil, and this can be achieved either from the percutaneous way or either from the endobronchial way. So this is the endobronchial way. Okay. And I'll show you the video. Okay, and I'll show you a typical one that is done by the endotracheal navigation. So first we use the navigation bronchoscope to guide us to the tumor site. And then we use the complete CT to confirm the location of the tip of the catheter, the navigation catheter. Okay, and then we will adjust the tip location under fluoroscopy, and after this, we use the dyno CT to reconfirm the location of the tumor, the catheter. Okay, and after this, we will do the dual localization. First, we inject of the ICG markers and the pleural surface. And after this, we put the microcoil on the deep margin of the lung, of the tumor, and then we do the surgery under the guidance of ICG and also the fluoroscope. And this will, so because we already put the microcoil on the deep surface, so you can do a good wedge resection. If you can see the microcoil was above the stapler, and that's a very easy wedge. Okay, and so we publish our protocol and to provide individualized localization strategy for every patient. And so I call this kind of approach as fluorescence-based localization strategy, and it is a personalized approach. So, and after talking about the wedge resection, so-called non-anatomical resection, and I move to the next part. It is the anatomical resection, and we know it is the segmentectomy. And I know Dr. Fang will talk a lot about technique about segmentectomy, so I will just briefly mention how we use the ICG during the fluorescence during segmentectomy. So the principle of segmentectomy is quite simple. We try to dividing the segmental artery, bronchus, and vein at a higher level. And I think the most difficult thing for segmentectomy is not to ligate the artery and vein and bronchus, because that's a smaller size. It is safer and easier. The most difficult thing is how to properly identify the intersegmental plane. And this is the old way, textbook way. During the open surgery, the surgeon will use the finger dissection and try to feel the intersegmental plane, to peel off the intersegmental plane. And obviously, this kind of method will induce a lot of air leak. And using a stapler is another way to avoid the air leak. However, it still requires some technique to identify the intersegmental plane. So in the past, there are two major methods, and we call this is a kind of the inflation deflation method. So for example, after you ligate the target segment, and you inject the air into the remaining segment, and that will help you to identify the intersegmental plane. And the other one, you can inject air into the segment you want to resect. And this can also help you to identify the intersegmental plane. However, these two methods are quite time-consuming, and after the inflation, it will take 15 minutes to identify the intersegmental border. And it is not a very practical way if you have many cases every day. So our approach now is using the ICG, and the principle is also quite straightforward. After we ligate the blood supply to the target segment, and we inject the ICG from peripheral vein, and it will go into the pulmonary artery, and then perfuse the segment that remain have the good blood supply. And when we see the border, and that is so-called intersegmental border. So this is the video that you can see. After the inflation deflation, you can see a plane like this. This is the inflation differential border. And then you use the ICG. We can see if these two borders are same. And in this case, it is very, we are lucky that the air border and the perfusion border are 100% match. And this is a good example of how we use both methods to identify the intersegmental plane. And you must ask me that in case that these two planes are not identical, what will you do? And now what I will do is I will try to use the border that has wider margin, and that will ensure us to have a good segmental resection. And we can do this for many different kinds of segmentectomy, not only for typical segment. We can also use for complex segmentectomy as well. This is the SX or basilar, and many different ways. And I just want to show that we can do everything we want like this. Okay, and we discussed about two kinds of sublobar resection, the wedge and segment. And so what's the worst scenario after sublobar resection? It is the recurrence. Normally, the local recurrence always due to inadequate margin, and the regional recurrence always related to inadequate lymph node dissection. So in terms of these two kind of recurrence and worst scenario. So what is the benefit of wedge versus segmentectomy and vice versa? So in my view, that the obvious benefit of segmentectomy is to provide a more extensive resection of the draining lymphatics, including the intersegmental planes. So if you require a good lymph node dissection, I think segmentectomy is better than wedge resection. And how about the other one? For wider resection margin, does segmentectomy always provide a wider resection margins? And I think the answer of this question is not so straightforward. We should depend on the tumor location. For example, for the tumor located in the middle of the segment, obviously, segmentectomy can provide better margin when compared with wedge resection. However, for the tumor that located near the intersegmental border, a simple segmentectomy could not provide better margin when compared with the wedge resection. And to have if you want to do the segmentectomy, in this case, you need to do maybe segment plus subsegment to acquire good margin. However, it is not worthwhile and cost-effective to do such a complex procedure when treating the small GGO lesions. So in my mind, that margin is more important in this kind of case. So I will introduce my concept that is so-called a hybrid segmentectomy. And I believe this kind of approach is easier and faster when compared with the subsegmentectomy. And to achieve this, you also need to have the ICG as well. Okay, and this is my protocol. So first, I call this kind of method as the dual injection localization method. So first, we will use our IVAS technique to inject into the tumor, local injection, and then we do the segmentectomy and ligate the segmental artery, and then we do the injection from the systemic circulation, and then if we have a good margin, and we can see a good hollow sign in these patients. So we use the hollow sign to determine if we have a good margin or not. So this is the video, so I'll skip this. Okay. So this is the localization part over here, and this is the intersegmental plane over here. So you can see a good hollow sign, and this patient has a very good margin of segmentectomy. So I'll show you several, one case that combine the old approach of I described earlier. So this patient, 55-year-old female patient, she has more than one GGOs in her lungs. You can see among different segments. So we design a personalized approach, and based on the tumor location and also the consistency of the mass. And finally, we do not only the dual marker endobronchial dual marker localization for this one, and plus by wedge resection, and we also use the hook wire for this one. And when we do the ICG segmentectomy for another one, then we achieve a multiple sublobar resection. Both have good margin and also good localization. So besides identifying intersegmental border and also the use of tumor localizations, there are still some other extended use of fluorescence in thoracic surgery. So first, I'll tell you, I also use this as the when I'm doing the lobectomy, and that is dealing with the incomplete fissure. So this is a case that we has incomplete fissure, and after resection, we feel that, oh, the perfusion is not so good. Maybe we divided the wrong place of the incomplete fissure. So we inject ICG to see, oh, there are there is a perfusion, a vascular zone at the tip of my middle lobe. So that means I have a wrong intersegmental interfacial plane. And so in this case, we do ICG first, and to identify the good where to divide the incomplete fissure. And this will help us to minimize the division of the wrong fissure and resulting some vascular air leak due to poor perfusion. And this is another case that we use this to divide, to identify where to cut the fissure. And another use that is for seismic surgeries, and we do the fluorescence to identify the phrenic nerve. So this is the picture the video after a very extensive total segmentectomy. And we can see, and this approach was while the subxiphoid. And we can see almost all the landmark structures in this case, including the inomial vein, and inferior vein, and also the major branches from the ascending aorta, that is the arch, inomial artery, and left common carotid artery as well. So, and when we inject ICG in this kind of situation, you can not only see the ICG flow from the inomial vein into the SVC and the heart. And the most important thing is that you can see where the phrenic nerve is. In patients with very obese mediastinum, it is very hard to identify the phrenic nerve, but by using this technique, you can identify the border of resection if you want to do the extensive segmentectomy. And that's another additional use of the ICG in not only the lung surgery, but also the mediastinal surgery. Okay, and you can see almost identical. And it is not due to the phrenic nerve itself. It is due to we can light up the vessel running together with the phrenic nerve, and that's very important things when we're doing the ICG during the mediastinal surgery. Okay, this is also so we can show you that you can do the same thing with different ICG system as well. Okay, and so this summarizes my talk that fluorescence-guided thoracic surgery, if you want to do it as daily daily practice, how we do it. So basically, I've covered how we do how we use the ICG for localization, followed by wedge resection, and you can use the ICG to identify the intersegmental plane, that is the segmentectomy, or either you can do hybrid segmentectomy, and also you can use it during the lobectomy when dealing with incomplete fissure, and you can use this as the phrenic nerve identification during mediastinal surgery. And also this one, I don't have time to talk about this. You can use the ICG to light up the sentinel lymph nodes. And in compare with the previous applications, this requires some time. You need to inject ICG into the tumor at least 30 to 40 minutes before surgery. Otherwise, it won't have enough time to light up the lymph nodes, the sentinel lymph nodes. And this slides conclude my talk. And again, thanks for the invitation. And I will be very happy to answer any questions. Thank you very much.
Okay, thank you for Professor Cao. How are you?
Hi.
Hi. Thank you for your excellent presentation. Professor Zhao introduced the application of ICG in thoracic surgery, including lobectomy, including segmentectomy, including wedge resection, but mainly in the localization of GGO. As we all know that there are a lot of ways to locate the GGO, such as bronchoscopy, hot wire, ICG, and so on, but each has its advantages and disadvantages. So we should choose the best way according to the specific situations. Okay, thank you for Professor Cao. And I will invite questions from other professors. Any questions to Mr. Cao? Okay, maybe there are no some questions, but I have some questions. The first one is that, compare to the inflation and deflation method, the application of the ICG in the identify the intersegmentectomy in segment plan. How long? It is very fast to disappear, right? It is too short to perform a segmentectomy. How to solve this problem?
Too short to identify?
Yes, time too short to disappear. Yeah.
So once we identify the proper intersegmental border, then we will use the electrocautery to do the marking. In case that the dye will disappear very fast. It will last for 2 to 3 minutes at least. So we have plenty of time to do the marking, and then we can follow the marking by our electrocautery, but not real ICG. Yes.
Okay. Thank you. So another question is the identified the market just in the surface of the lung, but we cannot market have the identification in the deep of the lung. How can you determine where the plan in the deep of the lung? You just use the intersegmental vein or something else?
Yeah. So as I mentioned that the penetration depth of the ICG is 2 centimeters. So for the nodules that was deeper than 2 centimeters, we prefer to use dual method, so that we will first put the microcoil at the deep margin of the tumor, and then we inject ICG on the surface of the crura. So, and once we enter the chest, we can see the ICG marking, and then we open the fluoroscope, and then we used our ring clamp or something to make an imaginary stable line. And then if we confirm that the microcoil is above the clamp, and that indicates that we have a good margin. So that's if you want to do the wedge dissection. But if you want to do the segmentectomy, that you just divide the vessel in the hilar, and you can have good margin. So my method, the dual localization, only applied to a deep wedge resection, but not segmentectomy. Yes.
Oh, deep wedge resection. Okay.
Yeah. Yes.
The last question is what is the method? What is the method you use to deal with the intersegmental plane? Energy or stapler?
Oh, yes. So my first choice is stapler. Yes, because I tried several times the Japanese way, using the electrocautery to cut into segmental border, but there are always some air leak, and I don't really like the air leak. But they always say that the air leak will stop in 2 or 3 days. but I don't like to have air leak after surgery. So I prefer to cut the intersegmental border by the mechanical stapler. And I think that's fast forward. That's fast and quick. And I think maybe the majority of the speakers, maybe you all favor stapler, maybe. Yes, that's my feeling. Yes,
yes, it will prolong the patient in the hospital time, right? Cannot charge in time because of the air leakage.
Yes, air leak is troublesome. But so we have to put a lot of sealants on the surface, and that adding some cost. Yes, and so I prefer a quick way. Yes.
Okay.
I have a question.
Yes.
Hi. It's an excellent presentation, Dr. Chow. Did you look at the cost effectiveness of using the hybrid method with the ICG versus performing inflation deflation to identify the intersegmental plane? Is it worthwhile to invest that much of money into the hybrid OT and all that? Have you looked into it in your practice?
So I just finished one randomized trial. It's just published this year. We comparing the hybrid OR pathway and versus the standard one pathway. But actually we are comparing wedge versus wedge, but not segmentectomy. Yes. So we transforming the patient to the hybrid OR, saving a lot of time and also the time and risk. So although we calculate that 1 minute in the hybrid OR equals 3 minutes in the normal OR. So it's triple the price. However, when you're adding the time, waiting time before the surgery, so these two approach are very similar cost. Yes, so that's our finding. So you spend more money during the surgery, but when you calculate all the waiting times and the time, the risk, everything, and we find that the two ways are almost same cost, okay. But the patient feeling is better. Yeah. So anxiety and everything is not a good thing for patients. Yes, and I think if we can prove that they are equally expensive, and then that is worthwhile to do it. Yes.
Okay, any questions? Okay, thank you for Mr. Sao. Thank you for your good presentations. See you later. Okay, let's welcome our next guest speaker, Dr. Narasimhan Sensamansi. Dr. Narasimhan Sensamansi is from Malaysia, the head of Thoracic unit, HKL Malaysia, member of an National Surgical Conjoint Board of Examiners, and other academic positions. Let's welcome Dr. Narasimhan.
Hi, thank you for the invitation to present and discuss on uniportal VEX bronchial sleeve resection. After listening to the fluorescence-guided segmentectomy and hybrid OT, I feel very humbled to present such a simple topic. So just please bear with me for the next 20 minutes or so. As for the disclosures, I'm receiving honorarium for this talk and I don't have any other disclosures. This is a brief content of my talk. What is bronchial sleeve resection, some evidence, and I'll be discussing on 3 videos of right upper sleeve, left upper sleeve, and left lower sleeve, and then a conclusion. So a simple definition of bronchial sleeve resection is a surgery to remove a lung tumor in a lobe of the lung and part of the main bronchus. And these ends of the bronchus are rejoined and any remaining lobes are reattached to the bronchus. This is based on the National Cancer Institute Dictionary of Cancer Terms. Basically what that means is, if, for example, if you have a tumor in the right upper lobe bronchus and it's encroaching to the right main, instead of doing a pneumonectomy, we can provide this patient a sleeve resection by cutting part of the main bronchus, part of the bronchus intermedius, removing the upper lobe bronchus and reattaching a clear margin bronchus intermedius to the right main bronchus. So that is practically what sleeve resection means for the bronchus. Some evidence that we have, there's no randomized trial to date on the comparison between VATS sleeve lobectomy versus thoracotomy, but all these case series that we have shows that patients who underwent VATS sleeve lobectomy versus thoracotomy have less post-operative pain, shorter time to remove chest drain, shorter length of stay, better preservation of pulmonary function, earlier return to regular activities with similar oncological outcomes, and most importantly, sleeve lobectomy prevents pneumonectomy and its complications. So both these papers were published. One was mainly for bronchial sleeve, VATS versus thoracotomy for non-small cell lung cancer, and the other is a double sleeve lobectomy, VATS versus thoracotomy for non-small cell lung cancer. And both these comparisons showed similar results. So we have a right-sided sleeve, left-sided sleeve, and carinal sleeve. In the right-sided, you have right upper lobe, lower and middle lobe. You can perform sleeve practically involving both lower lobe and middle lobe, or upper lobe or middle lobe alone. For the left-sided sleeve, it's pretty standard upper and lower. And you have carinal sleeve. And the commonest sleeve that most of us will perform is right upper, and left lower lobes. So in the coming videos, I'm going to discuss on the right upper. This is a video which we performed in 2019 of a 33-year-old lady who's pregnant during the diagnosis with mucoepidermoid cancer of the right main bronchus. So that's the tumor from the upper lobe encroaching to the right main bronchus. Here you can see the upper lobe is collapsed with the tumor coming from the upper lobe bronchus to the main bronchus. And so in this lady, we decided to wait for the pregnancy to be over, and we brought her in for a UniVATS right upper sleeve surgery. So first of all, the dissection is made to divide the truncus anterior, and using a vascular stapler, the artery is divided. Almost all the vessels are divided with stapler, and tried not to use clips or hemolocks because it will hinder in the suturing of the bronchus later on. So subsequently, the superior pulmonary vein is divided in the usual manner as how we do an upper lobectomy. And once the superior pulmonary vein is divided, we divide the anterior fissure following the plane of the superior pulmonary vein and the basilar artery, and is divided with a parenchymal stapler. And the same procedure is done for the division of posterior fissure, and is also divided with a parenchymal stapler. Once these fissures are divided, the next stage is to perform a lymphadenectomy to clear the lymph nodes and to expose the bronchus intermedius and right upper lobe bronchus. So, and for the right upper lobe sleeve, I'll usually divide the azygous vein to facilitate the anastomosis of the bronchus intermedius to the main bronchus. Some surgeons do not divide it, but for me, I prefer to divide. Station 2 and Station 4 nodes are dissected in the usual manner. And then the incision is always made in the normal bronchus that we are planning to preserve. So in this case, the bronchus intermedius, the incision made slightly oblique to make sure that the caliber difference between the bronchus intermedius and right main bronchus is compensated. And once the division is completed, you can notice that the tumor is completely occluding the upper lobe bronchus and encroaching to the main bronchus. And knowing the margin is more on the antibronchial side, we divide the right main bronchus as sparingly as possible, trying to avoid the tumor in the right upper lobe and the main bronchus. So we should try to at least macroscopically achieve clear division before sending the margins for frozen section. And once this is done, the upper lobe is delivered in an endo bag, and then the proximal margin is sent for frozen section. And here you can see that the main margin, the right main bronchus is about 1 centimeter from the carina. And after confirming the frozen section is negative, anastomosis is begun with a Prolene 3O suture in a continuous manner from the furthest posterior aspect of the screen to the nearest, and I normally complete the posterior layer first and then the anterior layer in continuous manner. So in this anastomosis, it's always good to remember the membranous part of the bronchus is always facing the spine. So as long as we have the membranous part facing the spine, the alignment of this bronchus will not run away. Also, during the anastomosis, we have to be careful not to injure the basilar artery that is running anterior to the anastomosis. So be careful of not accidentally injuring the pulmonary artery. And the suturing is done in a continuous manner, and subsequently it's tightened and knotted. So this is the last suture that I'm taking to anastomose the main bronchus of the bronchus intermedius. And once the knotting is done, the air leak is checked and allow the lung to expand well, and the lung expand when you can see there's no air leak. And this is the specimen. That's the X-ray. The patient went home on day 3 of surgery, and that's a bronchoscopy of the patient, the wound. So this is on the right upper lobe sleeve in 2019, and we went on to perform a left upper lobe sleeve in 2020 in a 72-year-old man with a squamous cell carcinoma with localized PET scan, and CT brain was normal. Again, you can see in the CT scan that the upper lobe is totally collapsed because of the tumor, and the tumor is here in the left main bronchus, and the surgery is done from the left 5th intercostal space, about 5 centimeter incision. This is a bronchoscopy view of the tumor. All vessels are again divided with staplers or suture tie without the use of clips or Hemalock. So here the A1 plus 2 A, B, and C was divided by together with a vascular stapler, and then the A3 is divided subsequently. Normally don't divide the vessels on top of each other because it can cause bleeding. So I'll take A3 separately. Once that's done, the division of the superior pulmonary vein is performed. And then A4 and 5. In here, I use a suture tie to secure the A4-5. And right after that is the division of the lower lobe bronchus. The lower lobe bronchus is the normal bronchus that I want to keep. So we divide the normal bronchus first using a size 11 plate and scissors. And then the left main bronchus is divided. Again, I'll try to sparingly divide the left main bronchus to prevent overzealous resection and having problems with the anastomosis later. But always send the margins for frozen section to make sure the margin is clear of tumor. Also be careful of not to injure the pulmonary artery that is running posterior to the bronchial structures. So that's the tumor, and the bronchial margin is divided carefully. Delivered in an endo bag. And subsequently, the bronchial margins are sent for frozen section. Both the main bronchus and also the lower lobe bronchus. And while waiting for the frozen section, lymph node dissection is performed. And performing this lymph node dissection is also important to mobilize the left main bronchus to enable tension-free anastomosis. We would use an endo blocker instead of a double lumen tube, because it enables the left main bronchus to be manipulated easier compared to having a DLT. So once the frozen is clear, anastomosis is started. And during the anastomosis, again, if for a left upper lobe sleeve, the pulmonary artery crosses posterior to the bronchial structures. So it's important to be very careful with the needling, not to injure the pulmonary artery, because if the bleeding happens, then the entire surgical field will be messy and will be difficult to perform a good anastomosis. Nowadays, many of us are performing this procedure non-intubated. But again, that is more reason why the bleeding should be controlled in a very diligent manner. So the principle is same, the posterior layer first in a continuous and then followed by anterior layer, just like how we perform a vascular anastomosis. And once the anastomosis is completed, need to be careful of not getting involved in two series of sutures being entangled, because that will delay the surgery and also complicate the anastomosis even more. So once the posterior medial wall is completed, then you have to go ahead with the anterior wall. And once the lateral wall, you have to tighten the anastomosis. I normally just use a hook to tighten it, and then test with water to make sure there's no air leak before putting the knots. Because once the knot is secured, it will be difficult to adjust the tightening, and you may need to put another suture. So I normally tighten it first, and then I normally check the air leak first, and then put the knots for the anastomosis. So this is the squamous cell CA of the upper lobe, and the post-op bronchoscopy. And the patient is a 72-year-old man, is discharged at day 5 of surgery after good rehabilitation and physio. And in this year, we perform another case of a 36-year-old lady with a carcinoid tumor who was planned for a pneumonectomy in another center, but we performed it. We managed to do a sleeve lower lobectomy for her. This is a 3D recon, and you can't see a lower lobe bronchus because the tumor is obtruding the entire lower lobe. And as for any lower lobectomy, you just mobilize the inferior pulmonary ligament and divide the inferior pulmonary vein with a stapler, and followed by dividing the basilar and S6 artery after dissecting the fissure and isolating in the usual manner. And once that's divided, the anterior fissure is divided. And in this particular case, I used the Ezisurg stapler. And the reason why I like is because of the stapling adjustment is easier, and the staple is only locked after you click the green lever. So it makes it easier to adjust the stapling device during the surgery. And then, as usual, divide the upper lobe bronchus first, because that's the normal bronchus that you want to keep. And in this lower lobe sleeve, the pulmonary artery runs obliquely to the anterior superior aspect of the bronchial structures. So you need to be careful not to injure them, for the same reason, though you don't want the surgical field to be messy. And then once the upper lobe bronchus is divided, the main bronchus is divided again, and using scissors. And the frozen section is sent always. And after confirming the frozen section is negative, anastomosis is started in the usual manner. The posterior layer first in a continuous manner, completing the posterior aspect, and then starting again the anterior layer coming towards the screen. So once the anastomosis is complete, so this is the last bite to complete the anterior layer. That means the whole anastomosis is done. And as usual, I will check my air leak before I put the knots. And once the lung is expanded well and air leak is not seen, there's no bubbling, the knots are thrown and ensure there's no bleeding from the stapler lines. And also the nodal dissection is clean with no evidence of lymphatic leak, and you can just close the suture. So that's the last bit of the surgery. Intercostal block given, drain inserted. That's the wound, it's about 4 cm. That's the resected lobe. The post-op bronchoscopy and the chest x-ray of the patient after the surgery. She went home on day 3 of surgery as well. So in conclusion, UniVET's sleeve resection is technically demanding and must be undertaken by experienced thoracic surgeon capable of handling complications by vets. Learning curve is steep and cases indicated for sleeve resection is rare. So you need to patiently learn the technique one at a time. It's a rewarding surgery, regardless of how the surgery is performed, whether open, multi-portal vets or UniVETs, because it simply prevents a pneumonectomy. Pneumonectomy itself brings high morbidity. So even if you can't perform sleeve resection by vets, it's okay to do the surgery by open, and it gives the patient a lot of benefits. Thank you.
Okay, thank you. Thank you for Dr. Narasimhan to give us excellent presentation. And Dr. Narasimhan showed us great surgical skills. We know that thoracoscopic sleeve resection is very difficult. So it's reduce the trauma of the open surgery and avoid pneumonectomy. It's very excellent. So anyone have a question? Would you like to ask a question to Professor Narasimhan? Everyone? Okay, I have a question, Dr. Narasimhan. I think that it's the most difficult thing to avoid a suture tangle in the suture anastomosis. Yeah, is there any types to prevent suture tangle? Do you have some experience? Yeah.
Well, one of the ways that that sometimes I use is to anchor the other end of the needle to the pleural wall. But again, that do not prevent suture tangling. You just have to be aware of the direction where we introduce the needle back into the thoracic cavity. Is it above the previous suture or below the previous suture? And when we remove the needle from the intrathoracic out, you must know that it's below the suture line or above the suture line. So that must be made aware, and the assistants can also tell you sometimes that look, the suture is tangling, go below, go above. So it comes with practice. There's no easy way in this.
Yes. Do you think the multi-top is easier than the uniport for the continuous suture?
Well, I think uniport is easier because you have an end-on view. You can use the retraction from another second port to retract the lung, but if you're used to doing uniport work, I think with the end-on view of the suturing, it's much easier with uniport compared to multiport. That's my view.
Okay. It's many thoracic surgeons has the same view, as the same appointments, just like you. Uniport's view, just like open surgery. Yes, just like open. Thank you for Dr. Marasimhan. Very great surgical skill. Thank you very much. Thank you.
Thank you.
Okay, let's invite the final speaker for the evening, Dr. Susan Canossi. Dr. Susan Canossi is the head of a cardiovascular system and a cardiovascular and thoracic unit, Colombo Hospital, Colombo Royal Committee, Thailand. Welcome, Professor Susan Canossi.
Okay, thank you for your kind invitation me to present in this kind of meeting. So, do you hear me? And you can see the slide.
Okay. I can see. Yeah. Please.
Oh, okay. Now this is the last presentation, but it's not least. So, the professor, every professor that present before me, they are talking about the ICG localization and sublobar resection. So first of all, I would like to introduce my institute. My institute is a name of Julapon Royal Academy. This is the name of the institute, and Julapon Hospital is the hospital under this flag name. This hospital established in 2009 and run the business along under the government. This is a government hospital under Her Royal Highness Princess Julapon Krompasi Sawangkawat patronate and support of the Julapon Royal Academy. So, my hospital is sit in Bangkok. Bangkok is a capital city in Thailand. We built up the hybrid OR in 2019, and we do the operation until today. Okay, now everyone know about our institute, and I would like to talk about the ICG localization. Everyone know about the localization technique, that because we use the localization technique in small lung cancer or small nodule, because in the past we cannot to identify the very small lesion like that Gallglass appearance or Gallglass lesion. It's like it be open, and to use our finger to palpate the lesion, sometimes we cannot find the lesion. So we try to find out which the technique that we can use to identify the lesion. In the past, we used like a pre-operative hook wire or microcoil placement, like Dr. Yin Kai present in before, or pre-operative dye that we use on digital palpation. This is a lot of technique that we used in the past. It have some benefit or some complication that we concern about this technique, like if we use the hook wire before we do the operation, sometime when we transfer the patient to the operating room, the hook wire is dislodge, display the lesion. So we cannot find the lesion when we do the surgery. This is some disadvantage of this technique. Now we develop the this instrument like a 4K instrument, 4K scope to use in the telescopic surgery in lung, and we combine to use with the ICT. The ICT is the indocyanine that we used in history before. We use in many kind of the medical field, like to use in the to measure cardiac output, to measure the hepatic function, or to see liver and hepatic blood flow, or used in ophthalmic angiography. The ICT is the chemical that have the spectral absorption allow 800 nanometer, and it have half-life around 150 seconds, and is less toxic to the human body. It's a small number of the patients have the complication from the indocyanine that when we use the complication or the side effect that we can have some report that they have some anaphylaxis. It's very rare of the report. This is a 4K of the scope, a thoracoscopic scope, or the machine that we use in combined with the ICT. The complication when we use this technique is pneumothorax or bleeding, needle dislodgement, or air embolism is very rare. But the pneumothorax, we can have some patient that we do the ICT before we do the surgery. We do the day, 1 day before do the surgery, so we can have some patient that have the small amount of pneumothorax, but it's not a serious problem that we in our experience. But bleeding is a very few of the patient have some complication like a bleeding. So we can use the CT guide preoperative localization of small nodule with ICT. When we use the ICT before the surgery, we can see the small lesion like this. For example, we use in the patient 76-year-old male. He have the 10-year ago of the squamous cell carcinoma at the lyso, and he received the wide excision. 1 year after, 1 year before, he had the recurrent of the carcinoma, and the chest X-ray show that he have multiple lesions at the left upper lobe. In this, we can see the CT scan of the case. He have the multiple lung nodule on the left side. In this case, we decide to do the ICT before do the wet resection. And fortunately, we have the hybrid OR, so we can do the ICT in the hybrid OR combined with the surgery. So this is a benefit of the hybrid OR, like Dr. Yin Kai already talked about this. We can reduce the time of the waiting time to the surgery, so we can reduce the risk of the complication, even though the complication is very small. But if we do like this technique, we can reduce the risk also. Yeah, after we push the needle in the lesion, and then we do the CT scan to find out that the needle is in the proper position before we inject the ICT. And this is a CT scan of when we do the ICT. So this case, we decide to do the surgery after that. in the same setting. You can see we can find out where is the proper of the lesion, and we use the stapler to cut out the lung nodule. So this is the benefit of the ICT localization. We can do a small lesion in the lung nodule. So this is now we move on to the talk about this segmentectomy. The segmentectomy is the sublobar dissection. The benefit of the segmentectomy is we can talk about the overall survival and cancer-specific survival of the patient. Even most of the patients that have gained this benefit is the stage 1 or stage 1A non-small cell lung cancer. We can do the segmentectomy and wet resection in this group of the patient. In stage 1 lung cancer group, the segmentectomy show that they have the benefit about overall survival and cancer-specific survival more than we do the wet resection. And the stage 1A group, it means that the tumor size is smaller than 2 centimeters. Maybe the segmentectomy and wet resection is not make a significant difference between this group. As we know that if we want to do the segmentectomy, we should to know about exactly what is the tumor and where is the tumor located in anatomical position. So we need to know about the segment of the lung exactly. And have many papers to talk about this compared to the segmentectomy and wet resection, that which one is give more benefit to the patient. Like this paper that show the segmentectomy, the result is the same as I talked before this. The segmentectomy in stage 1 lung cancer is give more overall survival than wet resection. For example, on this case is a 46-year-old female. She is asymptomatic, and 2 years ago, in routine checkup, show have the right upper lung mass and the size was increasing. So we decide to do the segmentectomy in this case. This CT scan show the tumor. You can see the tumor is on the right upper lung. Okay, now we decide to do the operation, and first we approach in the hilum and to identify the vessel. We use the harmonic to dissect the hilum. The benefit, the harmonic is I favor the harmonic more than to use the cauterization because it can stop bleeding well. And we divide the vessel. Mm. 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 And then we we define the bong cut. Mm. 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 So in the segmentectomy have the benefit in the some very high risk patient that cannot receive the standard lobar resection, and we need to preserve the most of the lung volume in this kind of patient. So this technique is have some some difficult or some need some learning curve and need more experience of the thoracic surgeon to do this. I think if we want to do this sublobar resection or segmentectomy, we need to do the standard lobectomy in some case and make a lot of the learning curve before we can do the segmentectomy in the safe procedure. Now, in sometimes we cannot do the segmentectomy in some case, so we need to do the lobectomy. Before we do the lobectomy, we need to check that the patient can tolerate well with if we do the lobectomy. The benefit of lobectomy is that is a anatomical resection, so we can control and we can do like a free margin of the tumor, and overall survival is a better than some case or some kind of the tumor, in especially in the tumor in the large side of tumor, we cannot do the segmentectomy. It give more disease-free survival in some case. So I think lobectomy is a necessary procedure that the thoracic surgeon, AV surgeon should do this kind of surgery. Like some paper that showed segmentectomy is in small size of the tumor or some kind of it, especially in the stage 1A lung cancer, we can do the segmentectomy and give benefit equal to the lobectomy. But in that case, we should select the patient in the high risk patient. We can do the segmentectomy instead of do the lobectomy. But in some kind of the patient, we need to do the lobectomy instead of do the segmentectomy. And the technique of do the lobectomy or segmentectomy we can do in the uniport or multiple port resection. It depends on the surgeon experience to that they can do the uniport or multiport surgery. I will show you a case of the lung tumor that cannot do a segmentectomy, so we need to do the lobectomy in this case. She is a 61-year-old female, and the routine checkup show that she have the left upper lung mass. When we follow up, the tumor have the same size, and she received the recommend that do the lobectomy in this case. So in this case, we decide to use the uniport surgery, lobectomy in this case. The CT scan show the left upper lung mass. Okay. Initially, we approach the hilum and to separate the pulmonary vessel. So we use the plastic bag to remove the upper lobe, and after that we do the lymph node dissection. Most of the patient we do the radical lymph node dissection. And this we release the inferior pulmonary ligament and we inject the Marcaine for interspinal box. Okay. And in my conclusion that if we want to do the segmentectomy or subsegmentectomy in very well, we should do the standard lobectomy or I mean that we should have the learning curve and experience enough to do the subsegmentectomy. Okay, thank you very much.
Okay, thank you. Thank you for Professor Susan. Thank you for your good presentation. And we all know that segmentectomy is very popular in all over the world. It's carried out by many doctors in big hospitals. And ICG is also very popular. And many professors like to use this, include some in localization of the GGO and the identify of the inter-segment length. And anyone else want to ask any questions? Okay, Professor Susan, do you think IgG has any disadvantages? How to solve this?
Pardon, say again, please. Hello. Dr. Singh, say again, please.
ICG has any disadvantages?
Any
For example,
advantages?
yes, in the deep side of the lung, we cannot see the color change, right?
Yes, if we inject through we cannot see the color. So if the lesion is not too deep, most of the lesion that we use the ICG usually sit in superficial of the lung. Yeah.
Also, we use this in the surface of the lung. You are right.
Yes.
Yes. Okay. Thank you very much. Thank you for Dr. Susan.
Thank you.
Okay, we'll finish if the conference near finished. It's very interesting. I would like to thank our 4 guest professors for taking the time to join us this evening, this conference. And I think it is a very interesting meeting tonight with surgeons from different parts of Asia. We all have our own characteristics and we can learn and from each other, right? I also like to take a moment to thank the organizers, the Ezisurg company of the conference, and of course, everyone who attend this conference. I think we can all agree that it has been incredibly informative and beneficial. I hope we will meet again in the future and to share our experience and practice in the future. Okay, thank you everyone for your time, this meeting, and see you next time. Bye-bye.
See you.
Thank you. See you next time.
Okay, see you.
Welcome to Ezisurg. We are committed to providing complete minimally invasive surgery solutions worldwide through the industrialization and R&D of high-end tumor minimally invasive surgery medical devices. In more than 10 years, we have tripled our functional floor space and developed technological and managerial know-how that allows us to compete on a global level successfully.
Our headquarters in Shanghai, our production facility does more than just produce minimally invasive surgical products. It's also an advanced competency facility, which allows our engineering and development team to work closely together to better test, optimize, and develop new cutting-edge technology.
We are committed to improving surgical outcomes in bariatric, thoracic, and colorectal procedures. Ezisurg has a comprehensive MIS portfolio focused on addressing surgical challenges. We create value all over the world. We're supplying medical professionals and treating patients in every continent. We fully support the development of academic interchange between surgeons, promoting the progress of new techniques, serving top medical institutions worldwide. We are certified by international standards such as FDA, CE marking, and MD SAP. At Ezisurg, we are committed to making people's life better. Welcome to Ezisurg. We are committed to providing complete minimally invasive surgery solutions worldwide through the industrialization and R&D of high-end tumor minimally invasive surgery medical devices. In more than 10 years, we have tripled our functional floor space and developed technological and managerial know-how that allows us to compete on a global level successfully.
Our headquarters in Shanghai, our production facility does more than just produce minimally invasive surgical products. It's also an advanced competency facility, which allows our engineering and development team to work closely together to better test, optimize, and develop new cutting-edge technology.
We are committed to improving surgical outcomes in bariatric,